there?
I am here, sir.
Namba?
I am here, sir.
Okay. Answer in Arambikiramba.
Yes, sir.
Good morning, all of you. Welcome to yet another edition, the 34th edition of our Clinical Neurology Forum. And I am happy to have Professor Kingsley as the chairperson. And I should congratulate Kingsley also. Kingsley, congratulations. He has been appointed as the medical superintendent of Kanyakumari Medical College Hospital. So I welcome him and congratulate him. And he will chair this session, wherein cases will be presented by the indomitable Dr. Balamurugan, assisted by Dr. Karthikeyan, the neuroradiologist at Salem. They will be presenting interesting cases, and I hand over to Kingsley to continue the proceedings. Professor Kingsley, you can take over. Thank you.
Good morning to you all. Sir, first of all, I thank Professor VN, who is my teacher as well as my mentor during my postgraduate days, and also till now, who has given this opportunity to be a chairperson. And also, I congratulate all the participants for being with us. And I also thank Professor VN for having this excellent clinical session. It is very useful to all of us. And I wish this should continue forever, sir. Thank you once again. So with this, we will go on to the meeting. First of all, I introduce Dr. Balamurugan. And also, I welcome him, sir, for his for sharing his experiences with us in this forum. That will be very. I think it will be very useful for us in our day-to-day practices as well as for patient care also. Dr. Balamurugan, we all know him very well. He has done his MBBS and MD at Tanjore Medical College, DM Neurology at a well-known institute in Immense, Bangalore. And he had a lot of honors as well as awards. His credit is a gold medal in MD General Medicine at Improving Bilingual Oration on Epilepsy in Tropics. He has done that. Best Paper Award at the Association of Physicians of India Conference in APCON 2005. And Teacher for Excellence Award in 2021 at SciCon and SciCon. Doctor's Day Award at EMS Salem.
On the road or coming, you don't want to catch one? Beat you. That's where.
And also Best Faculty Award in Indian College of Emergency Medicine 2023 and a South Zonal Member, Association of Physicians of India. He had a lot of publications as well as presentation and a contributing author in textbooks, Joseph Biller, Dijon. It's a well-known textbook, we all know, and Paul W. Brace's textbook Emergency Medicine and also CNS Infection. And more than 20 publications to his credit, more than 100 guest lectures in national and international medical conferences, course director fellowship in neuroemergencies by Indian College of Emergency Medicine, and currently the director as well as consultant neurologist at SIMS Salem Hospital, Salem. I cordially welcome you, sir, for this presentation. I hope this will be very useful for all the participants. Thank you, sir. Once again, I welcome. I hand over the session to him for his presentation.
Hello. Am I audible, sir?
Yes, sir. Yes, sir.
Yes, you are audible. Sir,
Very good morning to you all.
Ansari, please mute all the others except the speaker, please. And
Yes, sir. I will
the
meet it.
chairperson.
Yes, sir. I will meet it.
Thank you.
Very good morning to you all. At the outset, I thank Clinical Neurology Forum for giving us, the Salem Group, an opportunity to discuss some of interesting cases which we think may be useful in clinical practice. And my special thanks to Professor Dr. Kingsley Jabbar Singh, Professor of Neurology, Kanyakumari Medical College, for chairing this session on the Sunday. And our thanks to the mentor, the brain behind this clinical forum, Professor Dr. VN. Thank you, sir. Thank you for the opportunity given to us. And
thank you for joining.
Thank you, Professor, sir, for introducing me. And today's menu being Sunday, we'll start with some starters. I'll be showing some interesting pain syndromes in the neck and tonsillar fossa in the eye. Then the main course is mainly on neuro-otology. Then the finisher with some interesting clinical sign if time permits. Followed by dessert by my colleague and friend, Dr. Karthik, interventional neuroradiologist. And don't miss the desert, the mango desert from Salem. And my special thanks to all my teachers at Salem and from Thanjavur and from NIMHANS and all the people online for supporting this program. And let me start with some pain syndromes. Here is a patient who had pain in the neck, a typical syndrome. It's not a typographic error. It's actually typical syndrome, TI. This lady had presented to us with pain in the left side of anterior neck, radiating to jaw and face for the past 2 months. The severity increased for the past 2 weeks, pain aggravated by yawning, not by eating or drinking. So you can see here.
இல்ல இங்க இருந்து அந்த சைடுல இந்த ஜாஸ் இந்த இடத்துல எல்லாமே இந்த சைடு இந்த வலி வந்து ரீசெண்டா ஒரு 1 வீக்கா அதிகமா இருக்கு.
இது தவிர தலைவலி வருமா? அப்ப வெயில
யாரும் ஒரு நாள் கொஞ்சம் நம்ம வந்து தலைவலிக்கு தான் இருக்கும். பட் சரி நார்மலா இருக்கும்னு நினைச்சு நான் சும்மா இருந்தேன்.
ரெகுலரா மாத்த சாப்பிடுறீங்களா தலைவலிக்கு?
இல்ல இப்பவே நான் சாப்பிடுறேன்.
கையை வச்சுக்கிறேன் கரெக்டா இந்த ஜாஸ்தி வலிக்கும்.
So that's the point of pain. So pain more on touching a particular point, lateral to thyroid cartilage on left side.
No. Okay.
Yeah, that's the point of tenderness.
பண்ணும்போது வலி எங்க போகுது அப்படி?
இந்த பக்கம் தான் போகுது.
இந்த பக்கம் ஒண்ணு வலி இல்ல.
இந்த பக்கம் எதுவுமே வந்து
Denies any history of trauma. She was evaluated initially by ENT, treated with antibiotic, no relief. Throat examination, laryngoscope by on record is normal. And TSH mildly elevated, started on L-toxin, and her family physician referred for neurological opinion. Any thought process? In view of localized pain, am I audible, sir? In view of
You are audible. You are audible.
the video is also okay, good quality, and then audio video, sir.
Yes, very good, sir. The slides are also okay.
Yes. In view of localized pain and tenderness of the carotid artery at the bifurcation, a carotid pathology we considered, but of course, because of the pain in the lateral, being a neurologist, we always think about glossopharyngeal neuralgia and elongated styloid process. We asked for carotid Doppler. Already we got an X-ray from the ENT, which showed no elongated styloid process. X-ray cervical spine and X-ray neck was absolutely normal. So the carotid was inconclusive. We thought could be some focal lesions or something like a dissection, but no other features. And we proceeded with MRI, plain and contrast, with a particular diagnosis in our mind, because it was highly localized pain. And this is the plain MRI, the normal carotid on the right side. The left side, you can see the wall thickening, and the lumen is slightly narrowed because of thickened wall. So they have measured the thickening of the wall. It's 4.73 mm. Here, probably it must be less than 1 millimeter here, right side. And left, you can see the wall thickening. And a contrast enhancement was seen here in the periphery and in the media is also. So the report read like thin enhancing circumferential soft tissue thickening around distal left common carotid artery and left carotid artery bifurcation, causing the left carotid bulb marginally stenosing its lumen. The enhancing soft tissue lesion measures 5 mm in thickness and 35 mm in craniocaudal length. It was suggestive of perivascular inflammation of left carotid artery. What is it? So this patient was managed with short course of steroid, and after a week, she came for review.
70% மேல இருக்கும்.
Her ANA profile was normal, negative. So she could not recognize where exactly the pain had. So almost 70 to 80% disappeared. So is it carotidynia? A term first introduced by Fay in 1927 for an atypical neuralgia in the neck and face, pain and tenderness associated with application of pressure and on or about the area of carotid bifurcation called phase sign, An International Headache Society in 1988 classified carotid hernia as an idiopathic neck pain syndrome associated with a tenderness over the carotid bifurcation without structural abnormality. But the controversy began, and some people said it's a migraine variant. Some others said a symptom of various and heterogeneous causes of neck pain. And one group was strongly for differentiating this as a distinct clinico-pathological entity. In 2004, Headache Society removed the carotid hernia as a distinct entity from the main classification. Then a lot of works came for vasculitis. And then the MRI in 1997, first by Symes et al., abnormally enhancing tissue surrounding the symptomatic carotid artery. Then even with ultrasound, they could pick up this. And Leckler et al. Coined the term typic transient perivascular inflammation of the carotid artery syndrome to differentiate this from the general or broader carotid hernia group. So he advocated 4 criteria. If all are met, this is very classic for typic syndrome. The presence of acute pain involving the carotid artery with possible radiation to the neck, eccentric perivascular inflammation on imaging, exclusion of other diagnostic entities on imaging, resolution within a week, 2 weeks window occurring either spontaneously or with use of anti-inflammatory medications. So some people split into carotid hernia against typic and vasculitis, some others lump. So this is a broader clinical symptom, carotid hernia. You can call any person coming with localized pain in that particular area. If they have a radiological evidence, we can call it a typic. In that group, if they have evidence for vasculitis, we can call the vasculitis subgroup of typic. That's the message here. So typic syndrome is a new, distinct, unclassified entity beyond the myth of the general carotid hernia. I move on to the next case, again pain in the tonsillar fossa. I think I had given the clue. Yes, sir.
Bala,
Yes, sir.
why not at this point discuss carotid hernia if people want to ask questions, or you want to take it later?
So the 3-1 I finished, sir, the first starter.
Oh, okay, okay.
Sure. So pain in the tonsillar fossa, the 77-year man, pain in the left tonsillar fossa of 6 months duration. It was paroxysmal, shock-like pain, aggravated by eating, food particles touching the tonsillar area. Initially 2 months, pain relief achieved by carbamazepine 200 milligram per day. And slowly it was increased to nearly about 1000 milligram per day, and baclofen was also added. And you can hear from him.
எவ்வளவு மாசமா வலிக்குதுங்க? 6-7 மாசம். 6-7 மாசம். எப்படி ஆரம்பிச்சதுங்க? என்ன பண்ண அந்த வலி ஜாஸ்தியா இருக்கு?
சாப்பிடுறப்ப ஏதாவது மோதிட்டா வலி அதிகமாயிடுது.
சாப்பிடும்போது ஏதாச்சும் மோதிட்டா ஜாஸ்தியா இருக்கு. அப்புறம்
நார்மலா அப்படியே வலி வந்துட்டு இருக்கும். பேசும்போது கொஞ்சம் வலிக்கும்.
சாப்பிடும்போது மோதிட்டானா ஜில்லுன்னு சாப்பிட்டா அந்த மாதிரி ஆகுதா? காரணா சாப்பிட்டா
எது சாப்பிட்டா அந்த கையில ஆகால எது மோத
வலிக்குது கை.
So he was evaluated and CT brain was normal, not related to his pain, some calcified focus in the right frontal. And probably people thought it could be trigeminal neuralgia. They asked for an MRI and no vascular occlusion or malformation. And any thought process at this point, pain in the tonsillar fossa, what next? So, because
was it suggestive of glossopharyngeal?
Yes, sir. Yes, sir. It was pain in the tonsillar fossa. It was suggestive of glossopharyngeal. So, but he was saying that something touches the tonsillar fossa in the foot particle. I strongly suspect it is a glossopharyngeal neuralgia.
Yes.
So he is edentulous. That's the reason I am able to put my finger into his mouth. Otherwise, high risky. I could feel something on the tonsillar fossa. So I proceeded with the video laryngoscope, which our intensive care specialists do have. You can see here a small cystic lesion in the left tonsillar area. So we proceeded with the MRI of the neck to focus on the tonsillar area, which showed a nodule in the left tonsillar fossa, mostly benign. no infiltration surrounding as far as the radiology is concerned. Probably a neuroma or something, a benign lesion compressing nerve or causing problem. So pain in the tonsillar fossa, we neurologists always think about referred pain. Pain in the tonsillar fossa could be due to pain in the tonsillar fossa itself. The third one about the starter group we are in. This is a 60-year-old male presented with to ER with acute onset severe pain in the right orbitofrontal region for the last 2 days. Blurring of vision and photophobia of 1 day, had a red eye and watering of the eyes of 1 day, which was strictly on one side, right orbitofrontal. No complaints of nasal block or vomiting. Known coronary artery disease on antiplatelets with nitrates, but no link with the nitrates intake and the pain, and no past history of similar headache, and acute onset pain, right side, and you can hear from him. You can see the red eye, right side, and watering of the eye. Eye movements were normal. And there is visual disturbance. We thought it could be first attack of cluster, but when I put the torch, I was surprised to see that people was mid-dilated. He didn't visit ophthalmologist recently to account for pharmacological dilation. So, though I thought first attack of cluster, right eye pathology, giant cell arteries, carotid dissection, all those things, but the right people dilated, mid-dilated, not reacting light, worried. Any thought process at this point? So, because of visual blurring, and you could see mid-dilated and hazy anterior media, we thought it could be acute angle closure glaucoma, and we referred to ophthalmologist and they treated with the pilocarpine. He made improvement with that. And the question here is, why is people dilated in acute angle closure glaucoma? Increased intraocular pressure causes iris ischemia, thereby causing dilation. As a neurologist, we should be aware of this entity because this is an ophthalmological emergency. When we think about dilated people and then we go for a probable pecam artery being compressed by the nerve compressing the pecam artery, these are the thought process generally we think, but this is an ophthalmological emergency where they have to go for emergency, sometimes trabeculectomy. That we have to be aware. The clue here is that a red eye, photophobia, the hazy anterior cornea. And the last case in this group is again a right side headache, 3 days duration, a right eye pain, congestion, recurrent, short lasting, severe, no precipitating factor. So I thought it could be first attack of cluster or shunt or trigeminal neuralgia V1. So it was in the casualty. So the energetic duty doctor were discussing this case to me. I said that it could be a first attack of cluster headache. And then said, how do you say it's a cluster headache? Because the unilateral lacrimation, and it could be cluster or shunt. So we gave oxygen. She responded to oxygen, and we were happy. And we sent her with steroid. And the next day, 2 days later, the same duty doctor called me and then said that, sir, the lady with cluster had come with drug allergy. Now I gave the clue. So sometimes we may be fooled when we see the cases acutely on day 1, day 2. And this is a classical herpes zoster, which I thought could be a cluster headache. I think all patients can respond to, or subjectively respond to oxygen also. This patient responded to oxygen. And when I reviewed the first video, what I missed was here you could see some 1, 2, or 3 small lesions, slight redishness started on day 1 itself. What we missed was a cluster. Not a cluster, it's just a herpes zoster we thought it could be. So any case of first attack of unilateral headache, acute onset, be a physician rather than a focused neurologist to think about a cluster or V1 or a shunt. I think with this, I give a gap and we have completed the 15 minutes of starters. I'm ready to take up questions, sir.
What was the onset like in that patient with carotidynia?
It is of subacute onset over 3 to 4 days she developed, and at the end of 2 months she came to us. Sir. But the pain was severe the last 7 days.
So it was a continuous pain for 2 months
Yes, sir. Yes, sir.
of subacute onset.
Subacute onset, the pain was severe the last 2 weeks.
Oh, and the first such episode.
Yes, sir. First such episode.
Okay.
And it is well localized.
Okay. Thank you. Thank you.
Sir, is there any precipitating factors?
For the first carotidynia, that is typic syndrome, no precipitating factor, sir. And ANA profile were negative, and she is on follow-up. She has totally recovered, and she didn't have any recurrence.
Okay.
And
anything known about the etiology of such transient?
No, sir. Mostly they say that if some of subgroup may have vasculitis, they call as a localized vasculitis. If they have high ESR, CRP, or Procol or vasculitis workup positive, they can call as a localized vasculitis. Otherwise, they call this as an idiopathic, and most of the time they respond well to short course of even simple NSAIDs. Some of the people didn't treat with steroids; they have given only NSAID, and they had responded well.
Could they also show vascular involvement in the sense stroke-like symptoms?
No, sir. No, sir. None of the patients in the literature I reviewed stroke-like presentation. There is a uniform luminal narrowing, but not producing any intimal issues. Any intimal issues or block in the intima. It is a localized, sir.
Okay. Thank you. Thank you.
Shall I go with the main course, sir?
Yes, please go ahead. Whatever Kingsley says.
Yeah.
Yes, sir, you can proceed, sir. Yes, sir.
Shall I go with the main course?
Yes, sir, you can proceed, sir.
Yeah. After starters, we go with the main course and diagnosing stroke in the blink of an eye. So, Academic of Emergency Medicine recently released the GRACE 3 guidelines for reasonable and appropriate care in the emergency department on acute dizziness and vertigo in the emergency department, because most of the time now acute vertigo goes to the emergency department. The emergency department has to evaluate is it a stroke or not. Then they have to refer to stroke unit, and it has to be very fast. And then this is the guidelines they have recommended. And the recommendation one is emergency physician should receive training in HINS, head impulse, nystagmus examination, test for skew. And if they are dealing with acute vestibular syndrome, this is for acute vestibular syndrome. Acute vestibular syndrome is nothing but patients coming with acute vertigo, constant acute vertigo lasting for hours together, associated with nausea and or vomiting, imbalance, and spontaneous nystagmus, as defined in 1988 by Hodgson and Ballo. So if they come with acute vestibular syndrome, they say that go with the HINS. If acute vestibular syndrome with nystagmus, actually they should have nystagmus, then only AVS. So they recommend HINS with high certainty of evidence. They found some of the patients with AVS didn't have nystagmus. Who are they? And can we recommend HINS? They found HINS is not useful, and we had to go with some other additional clue. One additional clue they added was hard of hearing, and then they added ataxia. So we neurologists somehow that not very much very much good, or we are not more into the head impulse in practice. I may be wrong, but that's most of the time I see. But probably I'm not trained in head impulse when I was doing my post-graduation. So this is the way that it evolved, how to differentiate a peripheral and a central. Till 1988, we were looking at the peripheral nystagmus, Alexander's loss and all. HIT came in 1988, and from 1988 onwards, it is a real hit in differentiating a peripheral and central. And then HIT plus in 2013, HINS plus with hard of hearing with the ataxia. We know HIT head impulse test examines for all clinical purpose horizontal canal. So if the HIT is abnormal, we consider this a periphery, most likely vestibular neuritis. Most common cause of peripheral acute vestibular syndrome is vestibular neuritis. If it is a normal, we vote for central, we evaluate for central. This is the traditional textbook teaching. But we all know abnormal HIT can occur in central, especially ICA branch of labyrinthine artery is involved. If the labyrinthine artery is involved, it can involve only the labyrinthine apparatus, the semicircular canal and cochlea. So it is actually peripheral for anatomical and physiological means. But pathologically, it is a stroke, occlusion of the ICA branch. So that's the reason we call this pseudo-neurotic pattern of ICA. The same ICA, if the anteromedial or anterolateral brainstem branches are involved, in fact involves the vestibular fascicle and or the nucleus. So anatomically, it is central because vestibular fascicle is in the brainstem, the lowermost part of the pons or the uppermost part of the medulla. But physiologically, it is a first order neuron. So you get abnormal hit because it is a first order neuron. Till the vestibular nucleus, it is a first order neuron. Again, pathologically, it is a stroke. So this is the fallacy in hit head impulse test. And similarly, normal hit can happen in peripheral lesions. Peripheral lesion is most common being vestibular neuritis. Vestibular neuritis involves the superior vestibular nerve or superior and inferior. Very rarely, it can involve only the inferior vestibular nerve. We call isolated inferior vestibular nerve involvement. We know the inferior vestibular nerve doesn't supply the horizontal canal. It supplies the posterior canal and the saccule. So the horizontal hit may be normal if the person come with acute vestibular syndrome, even with nystagmus. Normal hit can happen if it is isolated inferior vestibular nuclei. With this fallacies, if the patient comes with acute vestibular syndrome, nystagmus and without nystagmus, two cases I'm going to show you. This gentleman, not a non-hypertensive diabetic, acute onset vertigo, vomiting, imbalance of just 4 hours duration. So the ER physician has to say, is it a vestibular neuritis or a stroke involving the pons or medulla? So now we can see obvious, even in the straight gaze or central gaze, he had a right beating, and right beating nystagmus increases on looking towards the right, and even towards left looking, it is a right beating. So he had unidirectional nystagmus, a right beating, which obeys the Alexander's law. So it's very classic for periphery. So now I'm going to show you the head impulse. Turning to the right and turning to left. The left is normal for me. Right, something is different. Now it is left, now right. Something is different, but it is not the catch-up second that we see. The eye goes to left and then comes back. Again, I show. The eye goes and then comes. It's more than expected it moves. So it is abnormal head impulse, but not we commonly see in periphery. Again, the head impulse is not normal also. So this is our lab showing for a better understanding about the right beating nystagmus. So he had a grade 2 ataxia, not grade 3. Grade 3 favus is central. So he was able to stand and he was able to sit. So as far as the hint is concerned, I'm not sure about this head impulse. We can vote is a normal or if it is abnormal. This is not the classic for a corrective saccade with head turned towards the site of lesions. It's overcorrection. But the nystagmus is for periphery and no skew deviation. So in that situation, if there is no clue for central, all or some are for peripheral, then they say that don't vote for central. Again, you go for these two. Again, this patient, no loss of acute onset hearing loss, and the ataxia is grade 2. So there is no clue for central as well as the hints or hints plus examination is concerned. So which is supposed to be 100%. With this chart, I have to say it's a periphery. This patient had a strategically located infarct in the left lateral pontomedullary junction. Now, with our vestibulo-oculogram, you can see here, this is gaze test center fixation is on. He's looking straight. Sorry, not this one, this one. So he's fixing his eyes, you can see. So right beating nystagmus. When I remove the fixation, again right beating, but you can see one thing that is obviously it is more, isn't it? But in addition to that, what interesting phenomena we could see is that the eye, once I remove the fixation, the eyes moves towards left side. The upper one, the eye is straight looking, and the lower one, I asked the patient look straight, but I removed the fixation that he is not able to look, it is in the dark. So I removed the fixation, you could see the eye goes towards the left. And what is it? Now you can see, even with naked eye, by asking the patient to close the eyes, the eye goes to the left and then comes back. When he opens, it comes back. It goes to left and then comes back. Every time he closes, the eyes goes to the left and then he opens it, gets corrected. This is ocular pulsion best seen on eye closure, on a blink of an eye. On eye closure, the eyeballs moves to left and on opening gets corrected to central position. So this is acute vestibular syndrome with nystagmus. All the hints +1, +2 towards periphery, but one strong clue of the ocular pulsion, ipsipulsion, made me to say this has to be something in the lateral medulla or in the middle cerebellar peduncle on the left side. More or less a similar case, acute vestibular syndrome, but no nystagmus. So can I go ahead with hints or not? Before going for hints in acute vestibular syndrome, I always recommend to the ER physicians, go for central signs, the basic principles, basics, never miss motor weakness, sensory loss, the dangerous disease like diplopia, dysarthria, dysphonia, dysmetria, and severe ataxia, the grade 3 ataxia, new onset headache and neck pain. Though less sensitive, if it is there in acute vestibular syndrome, is highly specific for stroke. I often repeat, if you don't understand obvious things, the subtle things won't matter much. So this patient didn't have any obvious central, but in acute vestibular syndrome, spontaneous nystagmus has to be there in acute vestibular syndrome. If it is a peripheral acute vestibular syndrome, that is vestibular neuritis, 97.4% had nystagmus. So there is no issues. Whereas central acute vestibular syndrome, they found that 41.5% didn't have spontaneous nystagmus. So who are they? Can I proceed with hints? No, this will confuse you. This may take you towards periphery or central. The value of hints in patient without nystagmus is none. Don't do it. Who are they? Acute imbalance syndrome, because they are not having nystagmus. Better newer terminology they have put is an acute imbalance syndrome. It could be a disease, cerebellar stroke. But I recommend to carefully examine a simple sign of ipsipulsion of eyes, lateral medulla, it takes us. It may be, if it is not that, it could be vestibular migraine, the most common group, which may mimic like a central or peripheral, and benign paraxional postural vertigo. Of course, this benign paraxional postural vertigo is episodic triggered, but some people can have a constant disease, especially when they have a cupulolithiasis rather than canalolithiasis. And sometimes it could be cardiac arrhythmia, partial hypertension. We discussed in the last clinical forum about the cardiac arrhythmia having a dizziness. So you can see the second patient without nystagmus. She had a normal eye movement and no nystagmus. And when I asked to close her eyes, the eyeball goes to left Once she opens, again it comes to this meter.
கண்ண முடிஞ்சு கண்ண முடிச்சு கண்ண முடிச்சு கண்ண முடிச்சு.
Yeah. So again, this patient too had a strategically located an infarct, and the same patient after 2 weeks, it is not her habit. She moves the eye towards the left when she moves her eyeballs. So now I asking the patient to look closer her eyes, and then you can see that this is a normal. She has become normal at the end of 2 weeks. So day before yesterday, I had another patient. So asking the patient to look straight, and I am removing the fixation with frontal glass. So the eyeball goes to the left. When I remove the frontal, the eyeball comes to the neutral. Again and again and again, you could see this phenomena. So the frontal glass is available for just 3,000 rupees in Enopa Medical College in Mangalore. You can order that. And do you really need a frontal glass for this? You can ask the patient to close the eyes and open. Close, open. Again, the eyeball goes towards the left and then coming back. So he had a left ICA, and probably this is one small infarct. This I am not able to pick up. When I repeat that, I may be picking up this, or it could be a middle cerebellar peduncle that causes that. So what is it? It's called oculopulsion, ipsipulsion, a forgotten sign of lateral medullary. Not only in lateral medullary, we can get generally acute conjugate eye deviation happens in a cerebral stroke with eye deviation towards the cerebral lesion that we know, or in a pontine stroke with eye deviation opposite to the side of pontine. That also we know that's a gaze preference or gaze palsy. What happens in lateral medullary syndrome or the ipsipulsion cases or contrapulsion cases that it is very unique. Conjugate deviation of the eye towards the side of the lesion in ipsipulsion. This is the most important part. Visual fixation needs to be removed to elicit ipsilateral gaze deviation. So often this is unnoticed. If we are not aware, we may ignore this finding. In one study, conjugate eye deviation was seen in 4 out of 14 patients with eyes open and 12 out of 14 patients with eyes closed. So this particular pathway starts from, for example, right inferior olivary. It goes towards the left medulla, left cerebellum, vermis part, Purkinje cells, again a left vestigial nuclei. From there, right superior cerebellar peduncle, right PPRF. So when the pathway is involved in site 2 lateral medullary, site 4 vestigial nuclei, it can be ipsipulsion. So we call lateral medulla and vestigial nucleus, it's a pull ipsipulsion. All others are push. That's a classical DM teaching for understanding and for your orals. So in the blink of an eye, you can diagnose a stroke if they don't have obvious central signs and your hints is not useful and your hints says the person is not having nystagmus. I feel that it's useless. Don't do it. Check for ocular pulsion. Don't miss stroke. So EQGOG is one mission that I use to learn. If you are interested in scientific way of understanding recording, I recommend this particular mission, and not for the promotional, because I say that this records the torsional component also. All other things records only the horizontal and the vertical. So I go with again another entity of just an eye movements, spinners in the trauma ward. And most of the time we may get a call from the trauma ward, or some of the patient had an injury to the head and then coming with you of vertigo. So this gentleman had a road traffic accident, transient loss of consciousness for 30 minutes, no seizures, no ENT bleed, diagnosed as concussion injury. On day 1, CT brain normal. On day 2, he had vertigo, vomiting, no headache. So underwent MRI brain, this was all normal, and no past history of hard of hearing, tinnitus. And you can see this patient.
தலசுத்தல் எப்போ வர ஆரம்பிச்சது? நேத்தி வந்துச்சு, அது இன்னைக்கு காலையா? நேத்திக்கு வர ஆரம்பிச்சு. எப்ப வந்தது? நேத்திக்கு மதியம் புரட்டு படுக்கும் போதே வந்துச்சு. புரட்டு படுக்கும் போது படுத்துட்டே இருந்தீங்க, ரைட் சைடுல படுக்கும்போது வந்தா, லெஃப்ட் சைடுல படுக்கும்போது வந்தா, அல்லது பின்னாடி படுக்கும்போது வந்தா? 3 டைம்லயும் வருதுங்க. ரைட் சைடு படுக்கும்போது கொஞ்சம் டியூரேஷன் ஒரு 10 செகண்ட் அதிகம் வரும்.
So he had a normal eye movement, and the history is that it's episodic. When he was lying down, the right ankle is more, but even on the left, on lying back also that. So it is some positional, but we are not able to say which positional. So eye movements were normal. And because it is episodic, triggered by position, in trauma, post-trauma cases, I prefer first supine roll test, not Dixalpine. On putting on a right lateral, now what you observed is a transient right beating nystagmus on turning to right side. Again, I show here, on turning to the right beating nystagmus or beating towards the ground. As a repeat, I have done. I have put the video. So it lasted for a few seconds. Then I asked the patient to turn on left. On turning to the left, it's a left beating nystagmus, isn't it? It's a left beating nystagmus or beating towards the ground. So consistently he had, so where is the lesion? What is the lesion? Post-trauma, he had on supine head roll test, on right turn, right beating, left turn, left beating. So, or on right turn, down beating, and left turn is also down beating, what we call as a geotropic. This is direction changing, position related nystagmus. Youngsters should not get confused with the direction changing gaze evoked nystagmus. Direction changing gaze evoked nystagmus always central. Direction changing position related. So always down beating we call as a geotropic. Always up beating we call apogeotropic. So it is geotropic variant of horizontal semicircular canal. So how to treat? We treated with the Guffoni, and I'm not going in detail about that. It should be a separate class. This is the way that we ask the patient to lie on the it is actually the right horizontal canal. So we ask the patient to lie on the left horizontal. How to say right or left? It's a geotropic, we can say. Right or left, there are two ways. One, which side is more nystagmus, or we can do bow and lean test. So the bow and kneel test is revealed that he is having a right side. So left side, he has to lie down. After a minute, we have to turn the head and he has to look down. And this is a post Guffoni, and he recovered, and there is no nystagmus. Always post repositioning, we have to redo that supine roll test. And when you are doing supine roll test, if it is no nystagmus, please go ahead with Dixalpic, because sometimes we may be taking the otoliths from the lateral canal, we may be pushing them to the posterior canal. So when supine roll test, no nystagmus, and Dixalpic no nystagmus, we can safely say that we have repositioned the otolith to the ventricle properly. He said there is no nystagmus at all. So this is post-traumatic horizontal canal geotropic variant responded to Guffoni. A similar patient, more or less same history, again trauma, and eye movements were full, no nystagmus. And she said that when she was getting up, she got the vertigo. So getting up most likely is a vertical canal. So most common vertical canal involved is posterior. So, but I always put the supine roll test. Supine roll test didn't show any nystagmus. So we went with next Dixalpic. You can see the Dixalpic right. This patient had an classical beating nystagmus within, yeah. When you have this sign, there is no differential diagnosis. It has to be upbeat, ipsitorsional, has to be right posterior canal. Yeah. So we train the patient. So this is right dixalpic, upbeat, right torsional. So it's a right posterior canal, BPV. So we treated with Siemens. So there's a way that he has to lie down on the right side for a minute. When they lie down on the right side, it's the right posterior canal, they will have a nystagmus. You can see this patient, when he was lying down on the right, you can see the nystagmus upbeat and right torsional. Then most important aspect is that very fast, we have to shift the patient. This step is most important. So we do it for 3 times and we recheck and we ask the patient to do 3 times a day. And when the patient is not improving at the end of 3 times, we can go for Siemens plus, or what you call extended Siemens. Michael Strupp strongly recommends to go for Siemens plus in the first instance. First, don't go for Siemens plus. Just we have to hyper extend the head. That's all, nothing else. So a day later, the patient came with no nystagmus and we rechecked. The check dixalpy was absolutely normal. So the risk of benign paroxysmal postural vertigo after head injury is nearly about 20%. And among the positional vertigo, posterior canal and horizontal geotropic are equally common. And most of the time it happens within 2 weeks. I say that it happens most of the time within 3 to 4 days. So patient coming with post-traumatic vertigo, instead of repeatedly going for imaging, once you do a simple positioning test, you can be very sure this is a positional nystagmus, what we call traumatic benign paroxysmal postural vertigo. And any post-traumatic vertigo, the message is it a continuous or episodic? If it's episodic and triggered by positional changes, first do supine roll test. Horizontal semicircular canal is equally common, but in non-trauma, it is always posterior, posterior, posterior. So in trauma, it could be posterior or horizontal. So supine roll test, then dixalpic for vertical canals. Canal repositioning is a treatment of choice and not long-term vestibular sedatives, which may cause triple P syndrome when you are not repositioning, only giving sedation. So I think this main course is over. I can take up some of the questions. If time permits, then I can go for the finisher. The finisher is just 5 minutes. Yes, sir. Professor VN, sir. Professor Chairperson, sir. Hello.
Bala, post-traumatic
Yes, sir.
is most often self-limited. Am I right?
All benign paroxysmal postural vertigos are all self-limited, sir. Because by natural, the way of we sleep. So if it is a horizontal canal, right horizontal canal, one of the treatment is forced lateral position. So what the advice is that when you are not able to do a positioning test, if the person is having a turning on right, the person is having a vertigo, ask the patient to sleep on left side for continuous 8 to 12 hours. Automatically it settles. That's one of the approved treatment protocol. So that's the reason when it is a horizontal, they improve well. So posterior canal, of course, it gets disintegrated over time. The canal otolith gets disintegrated. They can have a spontaneous improvement over 2 weeks. Very much possible, sir. But 2 weeks, the stress they undergo and the diagnosis without positional vertigo diagnosis, they may be going for repeated imaging, sometimes angio. That can be avoided when you can make precise diagnosis with positioning, sir.
Thank you.
Well, sir, it's a very nice presentation, sir. Thank you very much, sir. I think it's very useful for the participants. Any more interactions from the participants?
Yes, sir.
Sir Vijayan.
Yes, sir. Yes, sir. Nice, Vijayan. Yes.
Excellent, excellent demonstration, sir. This horizontal canal usually resolves on its own. Usually,
Yeah.
before they
Because
come to see
as
the
I told you, if it is the right side horizontal canal, automatically the patient themselves will go. They won't lie on the right side. They lie on the left side.
Yeah.
So that's a treatment.
And it is
Lateral
persisting,
position, the treatment.
yes. Yeah, what is it? And the maneuver sometimes is called liberatory maneuver.
Yeah.
Just push the patient to the side and then turn the head so that it faces downwards. And that usually relieves. But usually they get better before they come to see the doctor. The posterior canal is the one which is common. It's 80% of the postural vertigo is the posterior canal vertigos. And what I do is the Dix Hallpike and followed by the Epley correctioning. And then we ask the patient to at least stay in the busy OP, usually 30 minutes or 1 hour. And then I ask them to go home and sit straight for at least 3 to 4 hours. That usually resolves. Then most of the anterior canal, you have the extreme head hanging position. The same Dix Hallpike maneuver can be done in the extreme head hanging position. So basically, you convert the anterior canal into a posterior canal and then again do the Epley maneuver, the patient gets better. This is what I follow routinely in practice.
Yes, Vijay. I fully agree with you. In the spontaneous benign fraction postural vertigo, that what we call the Gordon variety, 70 to 80% is a posterior canal. 10 to 20% is the horizontal, and anterior is very rare, very rare. Okay, as you rightly said that. And it's a trauma, again, it is 50-50, horizontal, and then, so never miss doing a supine roll test. That's a message in the trauma patients. Or sometimes, we don't have time to do supine roll test and then go for Dix Hallpike. I said, in a Dix Hallpike, when you see horizontal, then you are very clear. Sometimes we see horizontal, not the upbeating or downbeating. So in the situation, we can say, okay, better I go for a head supine head roll head test, and then I go for a diagnosis of lateral canal. And Vijay, as you raised the point about the anterior canal, which is rare, it's a very rare. And anterior canal is, we say that it is probably a downbeating ipsitorsional is anterior canal, upbeating ipsitorsional is a posterior canal. Now, recently, I listened to Ajay Watts from Udaipur, one of wonderful presentation in our IAN online program. And he demonstrated a downbeating nystagmus on the right side. So I thought he was going to the downbeating right side was a right anterior canal. Then he showed after the procedure, this patient had upbeating left torsional. Upbeating left torsional has to be left posterior canal. How can a right anterior canal get converted into left posterior? It is impossible. Logically, it's not possible from the right ear to the left ear. And he had given a wonderful explanation. So whenever we see a downbeating nystagmus, first we always think it's a central cause. Second, we think it could be of anterior canal, but a downbeating right torsional could be a right anterior canal or a left posterior canal. The stone is in amplarian. He defined a new entity, and he said that amplarian, if the canalith or the otolith is in the amplarian, sorry, non-amplarian, so it can mimic because non-amplarian, if you ask a patient to lie down, that means the Dix Hallpike, from the non-amplarian, it goes in. So once it goes in, it is amplopetal. So the amplopetal causes downbeat. So he said that instead of saying anterior, always say posterior, because posterior is common. So anterior is very rare. So that is the last month I learned whether we are missing that group of anterior or we are missing that group of posterior non-amplarian. So next time that I have to see a person having a downbeat nystagmus. So before saying it's a anterior, would be the contralateral posterior non-amplary canalithosis. Thank you.
Yes, sir. Yes, sir.
Vijayan, bringing up this nice topic.
Routine dick salpike, if that occurs, one of the differential diagnosis is opposite side posterior in the routine dick salpike. And if you don't get it, if you do an extreme head hanging, then you get an anterior canal. The same thing if you do with an extreme head hanging.
Yeah.
Instead of 30 degree, you do an extreme head hanging, that is anterior canal. If you do it in the routine way, if you get it, it could either be the anterior canal or the opposite side posterior canal. Correct, sir. Yeah.
Bala,
Yes, sir.
regarding the posterior canal,
Yes, sir.
does Darrow's procedure or Darrow's exercise,
Yes, sir.
does it get relieved
Yes, sir. There are nearly about 35 ways of
specifically for posterior canal, I'm saying?
posterior canal. I am comfortable with Siemens, sir, because earlier I was doing Eplis, and then they have compared the Eplis and Siemens, and then they said that Siemens is easy to perform, and Eplis, if they have neck pain, literally we have to turn 270 degree, which is very difficult for them.
Yes.
And Siemens very easy for them to do. And more studies on Siemens coming up with more better reports of conversion. So Eplis is canalith repositioning, and Siemens, they say it is liberatory. So the name itself says that Siemens is better. But if one doctor is better in experience in doing one procedure, I would say that they can go ahead with that. If that fails, then they can go. Recently, I did Siemens. After hearing from Michael Stubb, I did, because the patient didn't get any improvement. So I did extended Siemens, and then the person got corrected. So that also happens. And as Vijayan said, one more important point, we make the patient to sit in the OPD for 1 hour or 2 hours. There's one more message I want to say. If it is a horizontal canal, when you are corrected properly, they will not make any complaints. They'll say that, oh, I got relief. It's like ear block got relief. When you correct the posterior canal, you are bringing the canalets from there to the another end. So that momentum will be there. They will be having some amount of nausea feeling, and they have the movement of the particle can have a sudden fall. So always instruct the patients to be at rest for at least 2 to 3 hours in your OPD, especially when you are correctly correcting the posterior canal. So I always say that when the patient has more symptoms of dizziness after correcting, that means it has moved out. That's one practical tip.
Exactly, sir. That clinical point is when you actually do the Epli and ask the patient to sit.
Yes.
If he complains of a sudden shudder or severe vertigo, which he has not had previously, that indicates actually it is curative. It is curative.
Yeah.
That point is curative.
Yeah, you got it.
What about the
it happens
recurrences?
in horizontal, then means you have converted apogeotropic to geo or geotropo. It can happen. Yes, sir.
What about recurrences?
50% of the people go for recurrence as far as the garden variety is concerned. I don't know about the trauma, sir. So they said that they, unless in the spontaneous vertigo, they said 50%, but they said 50% over the next 10 years.
Okay, Bala, one out of syllabus question or
Yes,
clarification. In those, as we know, these people go for recurrences.
Yes, sir.
Where would you place Anga Pradharshanam as a preventive?
So if it is a horizontal canal, that's a wonderful Anga Pradharshanam will be doing a wonderful job, because see, again, one more treatment for horizontal canal, you are not able to understand, localize is that geotropic or apogeotropic or confused. So just keep head shaking right and left for 5 minutes. There was one of the author has advised this, and automatically it will come to the ventricle or the saccule. So probably the Anga Pradharshanam is the one thing that it won't allow you to go into the lateral canal. It makes you, from the lateral canal, it comes to position, sir. So, but Sarasasanam is a little bit risky, sir.
Agreed, sir.
No, Anga Pradharshanam.
Anga Pradharshanam is very good, because Anga
Similar-
Pradharshanam is a lateral canal, not for vertical canals.
My take on this, sir, you can do the Balamurugan maneuver, or you can do the Coimbatore maneuver, or you can do the Chennai maneuver. When it is very difficult to treat, as Dr. Bala just said, I keep repeatedly doing the maneuver again and again. Instead of shaking the head, I keep repeatedly doing the maneuver again. After 3 or 4 times, it gets habituated, gets corrected sometimes.
Vijayan, but they have to come to you, no, repeatedly. These things they can do on their own.
Sir, I
We
I
have video, sir.
sometimes
We give it WhatsApp. Now WhatsApp is there. We give the video, and what I do is that I record the positioning and I record it and then give it to them, so that
yeah.
they can go and then do it.
What I do, sir, sometimes I ask the patient to lie down and ask him to turn either side. Simply turn either side. Or
Correct.
if he's slightly
Correct. That's it.
educated, keep a small pillow under the shoulder, allow the head to hang and turn either side. Very simple. Or else the Simons, very simple. Ask him to lie down either side
Yes.
10 times. That will do. Most of the time it works.
Okay, good.
Balamurugan,
No, I think UMS had a question. I think there was something UMS wanted to say.
Yes, sir. Yes, sir. Yes, sir. MS was there in Ajay Watt's talk also.
No,
About
no,
it.
now he had something. I thought there was a question or comment or whatever it was.
Yes, sir. Yes, sir. Yes, sir.
UMS,
Professor
are you
UMS, sir.
there?
Sir, I'm here. Nothing, sir. I'm just watching. Nothing. Just hearing.
Balamurugan,
I thought you.
Somebody had asked a question, so I just.
I am Dr. Alagason.
Yes, sir.
What about your experience with the residual dizziness following successful correction of maneuvers?
Yes, sir. Especially posterior canal correction, they will have residual, some persistent dizziness will be there that lasts for a few days, then it settles. Or if I have not corrected properly, if I converted the posterior to the horizontal, that means they may be having symptoms, and then I have to re-examine with the supine roll test or the dixalpate. There are two possibilities when they're having a residual. So one is that I have wrongly done that procedure and I have converted the posterior to the lateral or lateral to the posterior. I can recheck by do that. Even everything is normal, still they have that. It's well known in posterior canal correction. They will have a persistent dizziness for a few days, 1 or 2 days, and then they settle. And when we correct after about, I say that after 2 to 3 weeks later, and the more the prolonged duration of correcting, and they have, sometimes they may go for triple P syndrome also. That happens.
Sorry, Bala.
Yes, sir.
3PD, that's what you're meaning, isn't it?
Yes, sir. Yes, sir.
Tell me, repeat that again. When do they go for 3PD?
If they are not going for a proper rehabilitation in vestibular neuritis, or when the cupulolithiasis is constant, we are not correcting. They are having persistent symptoms. So when we are not correcting and then it keeps on going for months together or weeks together, they go for the triple P groups. And it can be pure psychogenic also, I agree. But these all the group, they go for 333, that we have to be careful.
See, when they are not corrected, you mean you mean the positional vertigo is not corrected?
Yes,
Sir,
sir. Especially
more commonly, triple PD is a long-term residual psychological problem, and it is usually triggered by a positional vertigo. Somebody experiences this once, then the fear of falling goes into that person, and then they go into this because by the very term, it's a perceptual dizziness. There's no objective sign, and the most the PPPD and it's not right always to talk about my experience, but even data would show that this is very commonly psychological. And it's very common when there is a prolonged positional vertigo, as can happen with the horizontal canal, more commonly than a posterior canal. The horizontal canal can go on for 18 days and 3 weeks sometimes. So it can happen.
See,
but,
mostly this.
It is just. Yes, sir. Yes, sir.
No, continue. You continue.
No, so the most important thing is to. I commonly would approach it this way. Every patient with the positional vertigo, I have had a positional vertigo in my life, and I know that for the next 1 week, I was afraid of falling. I think it can happen to the best of people. It was many years ago. So in that sense, I always tell the patients that the turnaround time is about 2 weeks to 3 weeks. If you don't get out of it now, and if you get addicted to this beta-histine, then for a lifetime, you will not get out of it. So that talking and getting them out is important early on. But then I've seen PPPD of 10 years and or more. who would resemble a very anxious patient who refuses to walk and all that. But I think the most important thing in those patients would be behavioral therapy. And escitalopram works very well.
See, mostly this 3PD, as UMS lastly pointed out, it happens when the patient is walking. So
Yes,
the
sir.
positional vertigo, which happens with regards to change of posture, is not necessarily that one which is troubling. It's only while they are walking, they have this. And
Yes, sir.
so it's a bit different from that sense from the usual positional vertigo which we are talking about. Though this is a positional because it's only in the erect posture and only when they are walking.
Yes, sir. Yes, sir. Yes, sir. This is different. This is episodic. That is constant. So
Rather
we
persistent.
cannot get confused these two things.
Persistent perception. Yes.
Persistent perception. Yes, sir. This is all the episodic. And when
Dr.
we are-
Balamurugan, in your first case,
Yes, sir.
there's acute vestibular syndrome of central etiology.
Yes, yes, sir.
Instead of doing the hint, standing algorithm, which is followed in most of the European emergency units, where very easily we can pick up the central cause, and even the emergency physicians, they direct to go for imaging department.
Allegation didn't hear your question properly. Allegation, can you repeat it?
So you want to say, ask the patient to stand, and then when they say to one side, that is more of central. That way, I'm not able to get you, sir. So hint is for head impulse and nystagmus and test of skew. And you are telling something different of easy way of going differentiating central and peripheral in those acute vestibular syndrome. And can you repeat, sir, that I'm not able to get it, sir?
Sir, my point is there is a algorithm called standing algorithm, which is followed in most of the European hospitals.
So what they do, sir?
The emergency physician attendant, they will do the test. They will look for nystagmus. They look for the direction of the nystagmus. They do the head impulse test, but they don't look for any skew deviation. But instead, they are going for a standing test. It's called the standing algorithm.
Standing means what will they show? The standing, they fall to one side.
Yeah, if they any swaying there, it's more of a central. They will directly refer them for imaging department.
But we all agree that when the acute vestibular neuritis patients also have swaying towards one side. So they say that's the reason hints they have added +1 and +2, what I call. First, they added acute sudden loss of hearing is more for central. Then they said that if there is ataxia grade 3, grade 1 can happen very well in vestibular neuritis. Grade 2 can happen in vestibular neuritis and also in the central. Grade 3 is grade 1 is very clear. Grade 3 is also very clear. Grade 2 can happen both the things. Grade 3 people, they will not sit at all. Okay, they will be obviously swaying. The ipsy pulsion will be very obvious. You can make the diagnosis. But any acute vertigo patient, they will have a swaying. So I don't think that with swaying to one side, we can make a difference between vestibular or cerebellum and saying it's a stroke. That's the reason they have
also say what is grade 2.
Grade 1, the grade 3 is very clear, sir. Not able to stand, not able to.
Are clear.
They are able to walk with support. Minimal support, they are able to walk.
Who?
Grade 1, sir. Grade 1, they are able to walk.
What is grade 2?
They need support to walk.
Between grade 1 and 3, sir.
Grade 3, they can't walk at all.
3, sir.
So anybody who
can't
needs
stand, they can't walk.
Sir,
grade
sir, one
2,
of
yes.
a good clinical clue, and I follow this and when the emergency calls, is can the patient walk with support? Well, they can't stand or walk without support. It is central.
Yes,
it's clear. That's very clear.
I think that's a very clear
grade
thing.
3 is very clear, sir. Grade 3 is always clear.
Yeah, grade 3, whatever. Simple thing. And even with support, if they can't stand or walk, it's a central thing. So I think that makes it easier.
No, the question is with support. That is where grade 2 comes in.
Yeah. 2 can happen in both.
In between 1 and 3. So then we'll have to go with an nystagmus. So it's actually at the bedside. My humble opinion is that it is not that difficult.
Yes.
The only part where you would have an issue is when somebody has a lesion at the lower pons where the vestibular fibers come in, if anybody has a lesion there, then even in central you can have impaired head impulse, and that is the only place where you might probably get a little confused. But at the bedside, I'm sure that with a good clinical examination, it is. I think it's a very hyped up topic, but what simple clinical neurology can usually solve the issues. I don't think I made a mistake with any vestibular syndrome, central or peripheral in my life.
Yeah, most of us don't make a mistake. Most of us don't make a mistake.
Yeah, that's what I said. For a neurologist, I'm sure it's the same experience.
Bala,
And
Yes,
most
sir.
of these are brought in by
what
VNP.
about the one leg stand? Is it helpful for?
It may be helpful to say that the person is having an imbalance problem, sir. Whether can it differentiate a central and peripheral, I don't know. But it may be helpful to say that the person is having some imbalance.
Advanced rhombox.
Sorry, can't hear you, you miss.
There's an advanced rhombox test, standing on one leg.
Yeah,
And
okay.
sometimes But I think it's
what
just
about
an
that?
indicator, sir. I think these are like finger nose and finger nose. So I think that is that categories where you are still, but I don't think it can differentiate to single. And if somebody can stand on both legs itself, then it's more likely to be a peripheral than central.
Yes, sir.
Okay, thank you, Bala.
Yes, sir. I stopped because already 12:10, and we'll move with
go for the dessert.
Second speaker. Second speaker. Desserts. Sir. Straight we go for desserts. Yes, sir. I come out, sir. Thank you for the wonderful opportunity, sir. Any more questions?
But the dinner
Yes,
is not complete without the spinners.
Spinners we completed, sir. Oh, okay. Spinners we did it. Yeah. Okay. Yes, sir. I move out. Oh,
Thank
sorry.
you, Bala sir. Thank you, Bala sir, for the excellent presentation and for the participants for the good interaction with us, sir. It is very useful. Thank you, Minister. Thank you.
Now, Karthik.
So next, I welcome Dr. Karthikeyan for presenting these interesting cases. Before that, I briefly introduce him, sir. Dr. Karthikeyan has completed his MBBS in Madras Medical College in 2015, followed by MD Radio Diagnosis in Ram Manohar Lohia Hospital, New Delhi. Then he has trained in endovascular interventional radiology in Kobe Medical Center, followed by European Board of Interventional Radiology in European Board. He has a vast experience during the post-graduation period, as well as a good experience in trauma radiology for 3 months, onco radiology in 3 months, interventional radiology for 2 months. And his experience in interventional radiology is very vast. Apart from cath lab work, he had a good experience in clinical work also. He had managed outpatient services and also triaging the acute ischemic stroke. What I want to say is he had a good experience in clinical work apart from the radiology also. He's a good academician, had a good many journal presentation, weekly case discussion also, followed by he had many publications to his credit, and he had many oral presentation in conferences as well as many publications. He had many achievements to his credit, awards in field of interventional radiology, and also he had been awarded for his academic competition in following radiology conference, that is in James, as well as in update in abdominal MRI in James in 2017. He's a gold medalist during his graduation period, a backlog memorial present in Medellin surgery, END gold medal, certificate of honor in Bannerman presentations. He had many e-poster presentation, he had more than 8 e-poster presentation, and he also a good organizer of many events also. I welcome you, sir, for this presentation.
Thank you for the kind introduction, sir. And outset, I immensely thank Clinical Neurology Forum for this excellent opportunity. And I especially thank Salem Brain Club, Dr. Malamurugan, Dr. Mahadevan for suggesting me in this forum. So I will go for four interesting neurology cases which we encountered in the last 6 months to 1 year, and we'll show about how we our thoughts and our understanding in management of these cases. Is my audible and screen everything is fine, sir? So I can go ahead.
Yes, sir. I can proceed, sir.
So the first patient is of Dr. Balamurugan, sir, 20-year male. He had a complaint of left upper limb pain, which was there for last 2 months, which was aggravated with physical activity. And he had a ring fingertip blackening, and which last 2 to 3 weeks. So this was treated elsewhere outside as a possible radiculopathy, as was managed conservatively without any further imaging. He just had a cervical spine MRI without any further tests. So now had come with complaints of slurring of speech with the facial deviation for a last 10 hours. So on arrival, his neurology GCS was 15, and there's a right mild hemiparesis. The power was 4/5. The left upper limb was normal. There's a facial deviation. There's no bulbar palsy, and NIHS was low, which is around close to 3, which is clearly low NIHS. And additionally, on the left upper limb examination, his pulses of the left upper limb was absent. There's a mild coolness in the fingertips, but however, rest of the hand shows a normal temperature. The motor movements and sensations was preserved in the entire left upper limb. And the fingertip, there's a blackening changes with the ring fingertip with the rest pain in the corresponding area. However, there is no rest pain in rest of the areas. Since his current issue is due to an probable acute stroke event, so the plan was to do a MRI brains protocol as a first imaging, followed by CT angiogram, because he has an absent evidence of acute and chronic ischemia of the left upper limb also. So this was his MRI imaging. The MRI imaging showed a post-circulation stroke with acute changes in the left hemipons, and there is also left medial temporal lobe involvement. The rest of the medulla, pons, and the cerebellum, everything was fine. So this was an MR angiogram. MR angiogram showed there's a basilar terminus occlusion. This is a bilateral vertebral artery. This is a proximal basilar artery, and there's a non-visualization in the top and the basilar terminus. His basilar tops and PCA was one PCA was reformed by the right PCA was reformed by the posterior communicating artery. However, his left PCA was attenuated. So we did a CT because his left upper limb pulse is also absent. So we did a CT angiogram. So CT angiogram showed there was an occlusion of the left subclavian artery beyond the first segment. So we can see at this point where the cutoff is there, we can see an additional rib. So this is a first rib on both sides, and this is a additional rib which is above the first rib, which is coming from the C7 vertebra. This is basically a cervical rib. At the exact side, the subclavian artery got occluded, and it has got a long occlusion coming from the starting of the cervical rib compression to the proximal brachial artery, and the distal brachial artery was reformed again with some embolic occlusion through the radial and ulnar artery. And his clinical limb was viable, and there was an embolic occlusion to the basilar terminus. So we did not understand how to connect these two pathologies, but or one of our possible hypotheses is this is an acute and chronic occlusion. So probably the proximal extension of the clot might have got fragmented and migrated to the basilar artery. That's why he has now presented with the acute stroke. So the diagnosis, our probable diagnosis was it's a left thoracic outlet obstruction due to a cervical rib causing an acute and chronic occlusion of subclavian artery, which is extending brachial artery. That is clear cut. And current presentation of stroke is probably due to an extension of a proximal subclavian clot causing an embolic occlusion of the basilar artery. So coming to the management, so there are certain challenges we faced. So first thing is in the stroke management. So this is a young patient, it's 20 years. It's an unusual cause of stroke, and he presented at 10 hours, and he's on arrival. His neurology was reasonably preserved, but his basilar is occluded. So we don't know how to manage this further. So whether to wait and watch with the medical management or to go for an upfront mechanical thrombectomy. So, so the second management challenge was he also has an acute and chronic left upper limb ischemia, but clinically his limb was viable. If it has to go for surgical intervention, the problem is it's a long occlusion. Along with it, there's a cervical rib, which is a cause that also needs the surgical excision, and presence of the coexisting stroke makes it a little complicated. So we discussed with the team, the vascular surgeon, neurointerventionist myself, and Dr. Malabargan's a neurologist, and we discussed with the patient also about the challenges we face, and we formed a treatment plan and discussing with the patient. So the patient did not want the upfront mechanical thrombectomy, so we planned for medical management, close neurological monitoring in an ICU, and mechanical thrombectomy in case the patient goes for a deterioration, and antiplatelet and anticoagulant was initiated to handle both the stroke and as well as the left upper limb acute on chronic ischemia. And regarding left upper limb acute on chronic, it was discussed with the vascular surgeon. The limb is viable, so the saturation is maintained, and his motor and sensation is preserved. So the plan was to continue medical management, wait for a stroke recovery, and then once he recovers from the stroke, then we can electively manage the upper limb ischemia later on to prevent recurrences. So he was started on aspirin with the clexane. So he was clinically fine and stable for 48 hours with no further NIHS worsening. However, after 48 days, he became drowsy and he became right hemiplegic. So now the plan is to do a reimaging. Reimaging is just to prognosticate regarding how to see the extension of the infarct and to do a prognostication and for counseling prior taking the patient, and plan for mechanical thrombectomy and a GA since it was a post-circulation stroke. So the reimaging remained stable. So the basilar terminus occlusion remained stable. The right PCA was patent. The left PCA distal PCA occlusion was there, and left subclavian occlusion and the left vertebral, everything is stable. There's no much changes in the occlusion pattern. And then the diffusion imaging, the left pontine infarct has evolved, but otherwise no significant new infarcts as compared to the baseline diffusion imaging. So there's a almost reasonably evolved evolution of the infarcts and the imaging, but with the clinical deterioration. Hence, to proceeded with the mechanical thrombectomy. So this was his right carotid angiogram. We can see the right carotid angiogram, the PCOM which is filling the basilar terminus and the right PCA. However, the left, there is no PCOM, and we can see there is a retrograde bile collaterals which is filling the left PCA territory, and due to the left associated left PCS occlusion also. So this was his left subclavian angiogram. We can see clearly the clot, which is at the site where exactly the CT angio was there, but the cervical rib was crossing here. And additionally, we noted, we can see the internal memory. This is the left internal memory artery, and the left internal memory artery is also got cut below this. Basically, there was an embolic occlusion to do. So this probably explains the fact that there is probably a proximal extension of the clot, and that has got fragmented, one to the basilar and one to the internal memory artery, and that possible explanation for the stroke. So this was his vertebral angiogram. We can see this is a vertebral artery, this is a basilar artery, and there's a basilar is occluded at this point. Since it's an organized clause and basilar terminus occlusion, the suction thrombectomy was done for the patient and the basilar was recanalized. This is a post-recanalization, and the post-recanalization, this is a right PCA, this is a basilar, and this is the left P1 and proximal P2 segment. So there was a distal P2 and P3 segment occlusion also, but we can see this vessel was very small caliber since it was only 20 years made, and his left PCA infarct has not progressed much, and also he had a very good collaterals which is supplying the left PCA territory, and hence was decided that better not to chase the PCA occlusion to keep the complication very less, and only the basilar occlusion will kill the patient, and this will be usually taken care of by the collaterals. Hence, was planned to come off after this and with a TK2C recanalization. So this was a retrieved clot from the basilar terminus. And post-op, he was extubated, and his post-op GCS was 14/15. Mild drowsiness was there, and hemiparesis was there. Mild improvement as compared to the baseline. However, he recovered well subsequently over subsequent days and mobilized well. So after further days, Dr. Malabargan managed, and with the physio and rehabilitation, he completely recovered to near normal. And so this, and then he was planned to discharge with an antiplatelet with a therapeutic anticoagulation to take care of the subclavian occlusion. So one thought we had is whether to address the subclavian occlusion also by endovascular means, but the problem is the reason is not only the occlusion, it's also a cervical rib cause. So unless we treat the cervical rib, this occlusion will go for recurrences, and even if and the limb is completely viable, so and collaterals are taking care. So anything we disturb by endovascular suction, sometimes the clot gets pushed into the collaterals and might lead to unnecessary issues. So we plan to manage with antiplatelet therapeutic anticoagulation, and the patient was started on aspirin with rivaroxaban and planned for CT angiogram after 6 weeks to assess the left upper limb revascularization and to plan definitive surgery to prevent recurrences in future. So this was his CT angiogram after 6 weeks. We can see a near complete recanalization of the subclavian and the brachial and the axillary artery, with few incomplete recanalization in the distal radial and ulnar. But this is your clavicle, this is your cervical rib, and this is your first rib, which you can see it is clearly get compressed. So now the jobs makes it easier, and he is also completely recovered from stroke. So now next to Dr. Karthikeyan, who's a consultant vascular surgeon in Salem. So he operated the patient, and this is the cervical rib, and so this is after the cervical rib excision. We can see the subclavian is artery is clearly removed of the compression, and the patient is currently doing well. So should we complete the discussion, or we can go for further cases, sir?
How long after the onset of the stroke the mechanical thrombectomy is done?
So after almost 48 hours after the onset, sir. Sure. In this case, after 48 hours from the onset, sir. Balmurugan, sir, anything from your side to add on, sir? Okay, sir. Shall I go for the next case, sir?
Yes, please, if there are no questions, yes.
Yeah. So the next patient is on another post-circulation stroke. He was a diabetic on irregular medication. So he had a complaints of giddiness and vomiting since evening. And he has not consulted any doctor. So next day, he has an increase in the severity of the giddiness and vomiting. So he was being taken to the hospital. On travel to the hospital itself, he has a complete loss of consciousness for 30 minutes. On arrival, his GC was E2, V4, and M6. He was deeply drowsy and responding to strong oral commands and pain. However, moving with all 4 limbs with suspected mild right asymmetry on the right side weakness as compared to the left. The left side was briskly moving. So the post-circulation was suspected based on the history and subjected to imaging. So imaging showed scattered cerebellar infarcts, the occipital infarcts. The brain, there's not much infarcts in the brainstem. So this was his MR angiogram, which showed focal attenuation of the left V4 vertebral artery. However, basilar artery was filling well, and like the PCA was normally opacified. But this was not explained the pattern of infarcts and the clinical symptoms. So this was an SW imaging, which showed a focal clot in the left V4. And in the post-circulation, the veins in the post-circulation was dark comparing to the anterior circulation, probably suspecting probably an increased O2. This probably explains an increased O2 extraction. That is like the brain cells are extracting more oxygen, whatever it is getting off. And so we did a non-contrast ASL perfusion imaging. So as a completion, so we noticed the basilar arteries, we can see there is red signals in the basilar artery and as well as in the PCA. So this indicates the flow in the basilar artery is relatively slow as compared to the other vessels. And there is relative hypoperfusion in the post-circulation and the bilateral occipital lobes. So our probable diagnosis in this case was left V4 acute on chronic occlusion, which is presenting with acute basilar insufficiency. And the patient did not have a PCOMS also. So that is why probably the patient, the brain, the post-circulation is not getting enough blood. So based on his clinical profile and symptoms, so we even though the basilar is patent and it is forward flow is there, but we decided with the neurologist and went to go ahead with an angiogram as well as thrombectomy. So this was his right and left carotid angiogram. We can see clearly there is no posterior communicating arteries which is filling the basilas, and he has a posterior cerebral artery which is perfusing by the collaterals. And this was his right vertebral, which shows a chronic occlusion and from the distal V2. And this is his left vertebral artery. And in the left vertebral artery, we saw there's a clot which is ruptured, and there's a focal clot sitting there. And and the basilar is perfused low, and PCS was not well adequately filled in the diagnostic angiogram. So hence, probably it's a basilar hyperperfusion plus or minus an embolic event is probably causing his progressive stroke. So hence, plan to proceed ahead with the mechanical thrombectomy. So initial it was declotted by using a solitaire. So this was a retrieve clot, and this is post thrombectomy. It shows now the basilar is basically filling, and all the branches are basically filling. And this is a segment after the retriever clot, which shows an underlying plaque. So to better and this is a dominant vertebral artery. So to better understand the disease segments, we did a 3D angiogram, which showed an underlying very significant stenosis and the diseased left vertebral artery, which is secondary uncontrolled diabetic mellitus. So since it was a dominant vertebral artery with a significant stenosis, so the patient underwent angioplasty with after the terafeban loading. This is post angioplasty, the improvement of caliber. However, the artery was recoiling again after some time, and hence discussed with an attenders and planned to go out with an acute stenting because we suspected probably this might reocclude again without a stent. So this was treated by a coronary drug-eluting stent. This post-stenting with the reconstruction of the vertebral artery, and those remained stable, and the patient recovered, extubated, and slowly recovered over a period of time, and is doing well. So coming to a third case.
Can you show the MR angios, please?
Yes,
of
sir,
that
sure.
patient?
Yeah. This was MR angiograms. Here there was a focal attenuation. Where the angiogram also showed the same areas.
Okay.
So
anything distal to that also?
Sir, distal to that it was fine, sir. Only at this area, sir. Distal to that vessels was fine. Only this area. The right, in case the patient didn't the right vertebral was normal for him, or the PCOMs were there for him, he may not have had this significant stroke unless it is a continuous embolic from here. So either it is an imaging showed probably hypoperfusion also, along with pattern of infarcts also had an embolic tendency. So it's like combination of hypoperfusion with an embolic recurrent embolic events.
Thank you. Okay.
Sir, one question, sir.
Yes, sir.
Is there any brainstem signs?
So he was very deeply drowsy, sir. He was he's kept his eyes very closed. So at that time, we did not focus on the examination at that point of time, sir. It was very. It's almost like we need to intubate him. So at that time, he was securing airway, but since it was very deeply drowsy, snoring, so we to secure the airway, we directly intubated him, sir.
Okay. Okay.
So next patient is an elderly male. There's no comorbidities. There's no any prior significant history. So he presented with the one episode of GTCS seizures, which is completely recovered. So it was GCS 15 and no neurodeficits. So the case courtesy Dr. Prabharan, consultant neurologist. So on imaging, the diffusion was normal, no problem. And the T2 we found, we found this retrospectively. So the venous sinus, superior sagittal sinus was more rounded. Usually it will be triangular configuration. Usually more rounded means like unusually more prominent. This we found it retrospectively. And on the T1 imaging, there were a few T1 hyperintense areas. So this was corresponding to the cortical veins. So it was concerning for cortical vein thrombosis. And so this, which was confirmed in an SW imaging, we can see there's a blooming areas in the cortical veins, which was confirmed to be cortical vein thrombosis. However, in a FLAIR imaging, we found there is a few sulcal SH, which can be explained by the CVT, but there was a subdural small effusion is also along with that. So, and by retrospect, there is some prominence of venous sinuses. So we interrogate with the contrast imaging. So contrast imaging shows pachymeningeal thickening, and there's an engorgement of the venous sinus. And sagittal plane, the supracellus distance was reduced space, and the prepontine system space is also reduced. So So how to correlate this CVT with this spontaneous intracranial hypertension? So but definitely has a features of some intracranial hypertension. So we entered with the spine imaging. The spine imaging, the SLEC was positive. So there's a longitudinal epidural collection in the thoracic spine. And so this is a T2 sagittal planes, which showing this is a dura, and the surrounding epidural CSF collection was there. And correlating with the CT, there is a discal spur in the lower thoracic spine. So the probable sequence of events is a type 1 spontaneous intracranial hypotension, which is presenting as a seizure. So the probable sequence of events for him is the discal osteophyte is causing a dural tear. It has caused a CSF leak, which is causing intracranial hypotension, which is leading to a venous engorgement. And because of the venous engorgement, rarely the patients can go for a CVT, and that was the presenting manifestation of our patient. The surprising thing was this: we asked a history of any previous headaches repeatedly, but he clearly said there is no any significant headache history. He says. So the spontaneous intracranial hypotension is a very rapidly evolving topics in recent times, and it is a continuous advancements happening. So the current recommendation is when there's a SLEC positive. So previously it is being managed by the non-targeted blood patch at the 2 levels. Currently, if facilities are available and we can go for an if the SLEC is positive, you can go for a prone ultra-fast dynamic CT myelogram to identify exactly the site of leak, and so that we can do a targeted blood patch at that level, so that the chance of healing improves us, and further repeat blood patch reduces. So, but because of the we explained the options to the patient was not willing for the CT myelogram. So, but on imaging, so the discal spur we are able to identify. So we suspected this is probably the site of leak. So instead of going for a non-targeted, we targeted using a CT cadence at this level, and with the help of anesthetists, we targeted at this level and gave around 20 ml of blood patch at this level. And so the patient so after recovery, the patient was also kept on short-term anticoagulant, and the patient recovered. And this is an imaging after 2 months. Now that we can see the venous sinus has completely normalized, and the subdural effusion has regressed. The supracellular and prepontine spaces the spaces has improved, and the ventricles also is little bit relatively normal caliber now. And this is a post-op spine imaging, shows the SLEC has disappeared, and this is the axial imaging of the same. So we classify CSF basically into 4 types. The first is due to a dural tear, which is a classical of our case. The type 2 is due to a diverticulum, which ruptures and that causes a continuous CSF leaks. And type 3 is a CSF venous fistula. And if the SLEC is negative, we actually do this will suspect the CSF venous fistula. And for this, we need a dynamic DSM myelogram to identify the site, so that targeted patch or a surgical ligation or a foraminal vein embolization can be done. Type 4 is we don't know the cause, where we go for a 2-level non-targeted blood patch. So this is my final case, the case 4. So it's a 70-year female. So no comorbidities. He had a difficulty in walking since last 1 year. So he has not much consulted anybody. So now came with complaints of complete immolated walk and bedridden since last 1 to 2 weeks. Bladder and bowel was involved. So the spine imaging was done. The spine imaging showed L4, L5, and L5, severe canal stenosis due to a disc disease with hypertrophy of ligamentum flavum. But these clinical symptoms of bowel bladder involvement, and there's an underlying cord is also was not normal. So there was a edema in the cord. And additionally, we noted few small flow voids along the cord. So it is not just a compressive myelopathy. There was something else to add on was there. And so we screened the entire spine. So there was a multiple flow voids along the cord, and there was a cord edema. So there's so this cord enhancement was there in the conus region with a few small and non-enhancing areas. So it's suspected to have a probable underlying dural vascular malformation in the spine, along with the compressive myelopathy in the lower spine. So we went before going for a definitive surgery, went with the DSA spinal angiogram. So in the spinal angiogram, the interesting thing was, so this was, so in this age, usually we suspect a type 1 dural AV fistula, but in this patient, the fistula was in the lower lumbar region, almost at the L4, lower border of L4. So the fistula was from the, so this is a D10 level. This is an anterior spinal artery we can see, and this is continuing as a arteria phylum terminal, and that is continuing as a single pole fistula, and that is these are filling the veins. So we can see this is an anterior spinal artery. Now the second vessel is starting to opacify, that is veins. So this is the congested veins, which is seen in the MRI as a flow voids surrounding the cord. And so to better understand the anatomy to plan further treatment, we did on-table Dyna CT. So where we inject a contrast in the directly at the target vessel, and we do a CT on the cath lab vessel. So we can see the fistula is located exactly at the lower border of L4, so which is much below the level of cord and the level of phylum terminal. So this is at the lower border of L4, and we can see this is just underneath the lamina of the L4. Now, these are very important, the treatment managing the patient. So this is a corresponding 3D image of the same. We can see the to understand the exact anatomy of location. So we can see this is supplied by the anterior spinal fistula and anterior artery, and the anterior spinal artery is very small. So anything to do endovascular will put the anterior spinal artery at risk. So this patient, and on the basis of the CT, Dyna CT anatomy, we can see that the fistula is located just below the lamina. And so it is very easy for the surgeon to approach, and it is at the phylum terminal level. So there will not be any cord, and it's only the nerve root will be there. So surgeon can easily separate it and ligate the fistula. Hence, it was discussed in the and also patient had underlying canal stenosis. So for all these things put together, this patient will be better managed with the surgery. Hence, it was discussed in a multidisciplinary team with neurosurgeon Palaniswamy. This was a spinal myelopathy due to a phylum terminal arteriovenous fistula associated with the lumbar canal stenosis. So probably the canal stenosis, long-standing canal stenosis might have got made this fistula as a reason. So using a Dyna CT anatomy, we know that it is at the lower border of L4. So using a C-arm, this level was targeted, and localized laminectomy was done for this level. And the dura was exposed, and we can see intraarterial. We can see there are two parallel vessels. We can see this is taking a U bend here. So this is the site of the fistula. So that was disconnected and ligated and cauterized, and so the patient slowly mobilized over a period of next few weeks. So usually the dural AV fistula, spinal muscular malformation, we classify into 4 types. The first is along the nerve root, which is usually supplied by the radicular arteries. The type 2 is a intramedullary AVM, where it is located, usually supplied by the anterior posterior spinal arteries, and it will be located within the pile surface of the cord. Where type 3 is a extensive juvenile AVM, where we'll have a segmental distribution of the vascular malformation along with the intradural spinal malformation. Where type 4 is a perimedullary AVM, where this will be supplied by the anterior and posterior spinal arteries and will be located outside of the cord surface. But this the difference between our case and this is, so the type 4 usually will be with the above the level of conus. In our case, it is much below the level of conus, and this is has a specific entity called as a phylum terminal arteriovenous fistula, which is different from the type 4 AV fistula. And this is limited to less than 50 cases in the literature. And so the treatment is the important understanding in this case is for any phylum terminal fistula, and if it is an anterior spinal artery supply, it's always a treatment is surgery. And the Dyna CT is extremely useful to exactly help the surgeon to identify where to operate and how to approach it. And thank you for this excellent opportunity. And
What was the outcome in that last case after surgery?
Sir, after a period of few weeks, he started to walk with support, but bladder involvement was not completely rectified. But currently, she is able to walk with support, sir. But bladder involvement still there, sir.
Thank you.
Thank you, Karthikeyan sir, for the excellent presentation. It's a very useful topic. I think everyone have enjoyed well, as well as any further interactions.
Sir, any experience from the group to explain the subclavian artery occlusion and then it is distal to the vertebral origin, but producing stroke in the posterior circulation. Any experience from the senior, sir? Because we searched literature, we couldn't get how, but probably this coming out, this is not the normal flow. It has to come out in the retrograde and then it has to go up.
So, Sendil here.
Yes, Sendil.
Yes, please.
Hello. So, have you worked up for hypercoagulable states in that case? Is it cervical rib is incidental probably, or there is some
Hypercoagulable is
condition?
negative, Sendil. We present in our
All
club
negative.
also. Not that it's negative.
Okay.
So he is doing well. And there is no other clue. Actually, it started with pain with somebody. Initially thought it could be a C5 radiculopathy, and then it's going on. It's a very slow progression. Over 2 months, he developed this occlusion. So generally, we don't see cervical rib causing, theoretical only we say that cervical rib is common, it won't cause compression, vascular compression, but unfortunately this patient had that. And as of now, we are not able to get any reason for that hypercoagulable state. Sir, Ishwada, sir? Sir? Excuse me, sir. He must be in. Vandandar, sir. He is our.
Well, I am very much available.
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
Very nice presentation. Yes. So we had about 30, 40 years ago, we had the same problem, one patient. And what we did that we had a cervical rib, as you said, it never causes the problem, say 20%, 30%. But that patient was presented with a stroke. Then we found that there is a cervical rib. And after recovery of the stroke, we did a cervical rib excision for that patient. He made a good recovery, this patient. So I think, and
So
also
the stroke was where, sir? Which territory did he have the stroke?
which one, sir?
SKC, that case with the cervical rib, you said had a stroke.
Yeah.
Which territory did he have the stroke?
Sir, he had a similar presentations, like posterior cerebral stroke only. But that time we did not do any MRI, nothing like that. We treated like any other stroke. Then we found in X-ray cervical rib. Later, we thought that it may be due to that one, and we dissected that one. And also he had a cervical limb ischemia also. So we thought it could be at that time. We never thought proximal extension to that one. So we just automatically treated that patient. And Balamurugan, as the important thing, as he said, in the headache syndrome, we generally, as a physician, that we always think of a neurology when a glaucoma, it's a very, very important thing. So we missed some of the cases. Later, we MRI, everything was done. Later, we found that it's a glaucoma. Like that, Professor T.K. Ganesan used to say, anybody to diagnose in the pre-eruptive phase of herpes zoster, he must be a genius, so used to say. So we do see chest pain and headache, and then later we found that all investigations done. Then we see that's vesicles. Then it's very, very interesting. All cases, everything is very interesting, useful to the common practitioners like me. Thank you.
Hello.
Yeah.
Yes, Justin.
Well, sir, whether the vessel wall imaging will be useful to localize whether it is an intraluminal pathology or extraluminal pathology in the posterior circulation as far as this left subclavian is concerned, sir.
Sir, so this case, the CT angiogram was very convincing. The cervical rib, normally we classify whether it is a complete cervical rib or incomplete cervical rib. The incomplete cervical ribs is just like it looked like an elongation of the transverse process. And while the complete cervical ribs, it comes an anastomose to the first rib also. And so we'll show the imaging here. So we can see here, there's a complete cervical rib and it is coming and anastomosing with the first cervical. So the subclavian artery usually travels between the clavicle and the first rib. So normally there'll be a good space, but because now it's a complete cervical rib, so there's a complete complete impingement of the subclavian artery. But whereas if it is an incomplete cervical rib, it will stop here. So there, those patients will not have much problem unless there is any fibrous band is also exactly in this. So in subclavian artery compression, most of the times the CT angio is enough. But in case we are suspecting, sometimes the other thing is when there's a fibrous band in the incomplete cervical rib, what we can do is a dynamic. So first we ask the patient to do a scan in the we're keeping it in the lower down position. Then it's like doing an Adson test. When you're doing an Adson test, when you elevate your arm, so you will have the loss of pulses. So the same thing we demonstrate in imaging. When we elevate it on, we will see whether the subclavian is getting compressed or not. So normally in the elevation and keeping it little abducted, this costoclavicular space gets reduced so that the compression becomes more. But in this patient, even in the normal, because it's a complete with the anastomosis here, so even in the normal, it was a complete compression was there, sir. So we can see.
Karthik, sir is asking, the
Yes.
subclavian, we are very clear.
Yes.
For posterior circulation, we are not able to explain the subclavian getting down or retrograde. So
Yes,
for
sir.
posterior circulation stroke, by vessel imaging of the posterior vessels, that is posterior circulation vessels,
Yes, sir.
whether it helped us to say a different etiology or the etiology being a vasculitis, that is the key. I mean,
Okay.
it's just
Yeah,
Yes, sir. Yes, Balan. Yeah. Are
Yeah,
you dealing with any others like a Takaso like thing?
yeah, that's the thing that we found that in addition, he had a cervical rib that has precipitated that the so-called cervical rib. We are very clear that it's causing compression.
Yeah, that
Whether
is clear.
in this case, a posterior circulation vessel wall imaging of the vertebral artery and basilar artery would have helped. That was the question. And the
In
clot
acute
is there.
setting-
The clot is there. What is that thing? That's the thing.
In the acute setting, vessel wall imaging will not help, sir, because whenever there is a clot, there is always an inflammation going in that area. So the vessel wall imaging will be always abnormal whenever there is a clot. So if you want to do a vessel wall imaging, maybe we can do it intervally, like after the later on, once the stroke recovers and waiting for the inflammation. So in acute setting, the vessel wall imaging may not have a very good role, but in this case, we are very clear. Even the SWA, we saw the clot was there within inside. So may not have helped in this case, but definitely to differentiate whether it's a vasculitic pathology or general pathology, vessel wall imaging just an addition in addition to the clinical and laboratory findings. It is not a standalone test to interpret. So we many times we feel the abnormal enhancement looking like a vasculitis, but the patient will be having uncontrolled diabetic and hypertensive. In that case, the vessel wall imaging findings, we should not overestimate that is a vasculitis. We should keep in our population still we keep an atherosclerosis.
Yes, Karthik, as you rightly said, but in this case still we are not able to find any cause, as Professor Justin has suggested. Why can't we go for a vessel wall imaging after 2-3 weeks when he has recovered almost? So complete the workup, because we don't know the cause. As of now, we don't know. The vascular workup is negative and our hypercalcium is negative and everything is negative. Still, we are not able to find out the etiology for the stroke. As Sir has suggested, a good idea, sir. We will go ahead with the vessel wall imaging once he comes for follow-up after 1 or 2 months. Is it okay, Karthik?
Sure, sir. Sure, sir. We can go ahead.
Yeah. Thank you, Balan. Thank you, Karthik. Thank you.
Kingsley, anything else?
Yes, sir.
We are on time, sir.
Yes, sir.
No more interaction.
Absolutely.
Is there any interaction? We can continue. Otherwise, it's a good excellent presentation by Dr. Bala and a good radiology presentation by sir.
The Salem team.
Thank you, sir. Thank you for the opportunity. A great learning and great reading. Thank you.
For us,
and great
great learning for us.
Yes, sir.
I invite you all to come to Salem. We have ERCOT, but the season is actually in July, August, and Dr. Mahadevan knows very well. And from Salem Brain Club invites you, anybody who have the plan to go to the ERCOT, just visit our Brain Club and we'll be interested in learning your lectures at Salem. Thank you, sir.
Thank you, Bala. Thank you, Karthikeyan.
Thank you, sir.
Thank you, Salem team. And thank all the participants and the discussants. And thank you, Kingsley, especially for you to come and share this session.
Okay, sir.
Thank you.
Thank you. Sir.
And may I remind you that next month you will be presenting cases from Kanyakumari Medical College.
Oh, nice.
Yes, sir.
Yes, sir.
Thank you, sir. Thank you.
Thank you.
Thank you, Ansari of Sun Pharma.
Yeah,
Thank you, Ishwaradas. Thank you, Yomas. Thank you, Vijayan. Thank you, Justin. All the other participants who took part in the discussion. Thank you all.
Thank you, sir. Thank you very much, sir.
Thank you. Thank you. Please
All of us,
do.
thank you very much, doctor.
Yeah, please do continue to participate.
Thank you.
Ansari, can we leave?
Yes, doctor.
Okay,
Yes,
thank
doctor.
you. Thank
Yeah.
you.